costs, the committee noted concerns about instances where patients still incur expenses. To mitigate this, Honorable Speaker, the following activities are being undertaken. A, creating awareness and sensitizing the public on the applicable benefits and tariffs for informed decision-making in choice of facility. B, reviewing the benefit package and tariffs in collaboration with the benefit package and tariff advisory panel. And C, SHA will submit to Parliament a list of healthcare facilities where patients on shift contributions will receive a comprehensive payment without co-payment and with no co-payment. Honorable Speaker, on the difference between SHA and Taifa Care, Taifa Care is a Kenyan government initiative aimed at achieving universal health care, ensuring that all citizens access equitable, affordable, and quality healthcare services. The initiative focuses on 4 key pillars: sustainability of the healthcare financing, digitization of health systems, enhanced human resources for health, and security of health products and technologies. This program encompasses legislation measures designed to strengthen the healthcare system and reduce financial barriers for all Kenyans. Taifa Care components are Primary Health Care Act, Social Health Insurance Act, Digital Health Act, and Facility Improvement Act as enacted by this House. On the other hand, the Social Health Authority, established under the SHE Act 2023, with the core mandate of pooling financial resources and risks and strategic purchasing of healthcare services on behalf of Kenyan people, towards strengthening health financing for UHC through management of 3 funds, namely Primary Health Care Fund, Social Health Insurance Fund, Emergency Chronic and Critical Illness Fund. On the status of debts inherited by SHA from the National Health Insurance Fund and plans in place to clear them to ensure seamless service delivery. Honorable Speaker, this is a very important fact because the defunct NHIF owes healthcare providers an estimated 30.9 billion. Additionally, NHIF owes co-insurance Kenya shillings 8.137 billion for civil servants, wiper claims, and a further 3.97 billion in accumulated wiper claims before April 2021. NHIF also has outstanding premiums receivables totaling 25.5 billion across various government-funded schemes, including the Civil Service Medical Cover, Linda Mama program, and indigent support as annexed. These delayed payments have disrupted service provision, putting pressure on both public and private health institutions. SHA has been engaging the various MDAs with a view to recover the outstanding debts owed to NHIF to facilitate payments of debts to providers by SHA. Honorable Speaker, concerning the NHIF benefits were made favorable compared to SHA despite SHA collecting higher premium contributions. SHA benefits have a wider scope of coverage compared to NHIF benefits. The contribution design for SHA is based on the solidarity principle, where all persons contribute according to their ability to pay and receive similar benefits and tariffs. This is largely due to SHA's potential for larger pooled resources and risks, enabling broader coverage and enhanced access to healthcare services. The SHA benefits ensures access to full spectrum of healthcare services from prevention, promotion, curative, rehabilitative, and palliative care. Further, SHA benefits are equitable, affordable, and accessible to all Kenyans in line with Article 43 of the Constitution. A comparison between NHIF and SHA benefits, we have an annex which I'll be able to table here. On the status of staff and whether they will be absorbed by SHA, Honorable Speaker, despite paragraph 1 of the SHIF Act, where the board of the Social Health Authority established under Section 4 of the Act shall competitively recruit and appoint its staff under Section 17 of the Act, subject to the approved staff establishment and on such terms and conditions of service as may be determined by the board. Notwithstanding the provisions of this paragraph, the staff are eligible to apply for the positions advertised by the authority and may be considered for appointment where they are suitably qualified for the positions advertised. Despite provisions of paragraph 2 and 3, the authority review the qualifications of all the staff of the fund and shall, with appointment of its staff, give priority to the staff of the fund who are found to be suitably qualified for the positions in the approved staff establishment. The staff of the fund not appointed to the authority under paragraph 2 may exercise his or her option to either retire from public service or be deployed within the public service. Currently, on the status of update on the NHIF staff transition, Honorable Speaker, the Share Board has since sought the advisory of both the Attorney General and the Public Service Commission on staff transition. On 21st November 2024, all 1,737 staff of the defunct NHIF were taken over by the Public Service Commission and subsequently deployed to SHA for a period of 6 months or until when SHA completes recruitment, whichever comes first. The SHA Board has since reviewed the HR instruments and submitted the same to PSC for approval. Suitability tests scheduled to commence before end of February 2025. On concerns that data captured by SHA is inadequate, frustrating patients seeking treatment, and measures being put in place to ensure data accuracy. Honorable Speaker, the data captured by SHA is adequate to ensure provision of service. However, there are challenges faced by patients and measures to address them are ongoing. Further, the authority noted that some Kenyans do not complete the registration process, especially those that only register through USSD, code *147# channel. This group of Kenyans have not gone through the means testing process that enables them to make payments under SHIF and are not eligible for SHIF services in level 4, 5, and 6. On the lack of medicine in hospitals where patients receive treatment but are not given prescribed medication, Honorable Speaker, the Ministry appreciates the challenges of health products and technologies, and KEMSA business model was disrupted in 2019-2022 to the impact of COVID-19 health products and technologies. The procurement of COVID-19 HPDs during 2019-2020 period significantly impaired the authority's cash flow. Additionally, the authority has been burdened by significant receivables amounting to more than 6 billion as detailed below. As such, the organization's sustainability model has been facing various challenges, including inadequate financing to procure HPDs with a funding cap of 5 billion. Debt repayments by among them being the county debts amounting to close to 3.5 billion, with more than 2.7 billion over 90 days old. Counties work with KEMSA in generating forecasts for what is stocked at KEMSA. However, when it comes to procurement, they opt to buy elsewhere. The committee will be having a meeting with the KEMSA to develop a way forward. On this issue, Honorable Speaker, to support, we intend to improve HPT availability by recapitalization of KEMSA with a budget allocation of up to 5 billion to replenish deteriorating capital in order to break the various cycle of debt, pending bills, and low order fill rate. The National Treasury has so far allocated 1.5 billion to be factored in supplementary 2. This will boost the availability of essential health products and technologies for universal health coverage. Additionally, the authority is engaging the county governments to pay long outstanding bills, currently standing at 3.5 billion. On a report on the public participation conducted before and after the rollout of SHA, Honorable Speaker, the Ministry has placed advertisements on print media on 28 November 2023, and the regulations were also developed and posted on official website. The analysis of the views and submissions expressed during the consultations and engagements indicated that the principal regulations, particularly the benefits package in the principal regulations, amended regulations, and tariffs for health services, will facilitate realization of universal health coverage in the country. A clear framework has been provided in principal regulations for the review of both the tariffs for healthcare services and benefits packages offered by the Social Health Authority under the Primary Healthcare Fund, the Social Health Insurance Fund, and the Emergency Chronic and Critical Illness Fund. On concerns that SHA branches are unable to adequately address customer challenges at the local level due to connectivity and system hitches, Honorable Speaker, system availability currently stands at 98.2% as at 7 February 2025, 12:38 a.m. Digital Health Agency is working to stabilize the system to meet targeted 99.99 availability. In order to address these challenges, the system configuration is ongoing with a target of completion by the end of February 2025. The agency is also fast-tracking the integration of existing hospital management information systems and claim management systems to further enhance efficiency in operations. This will improve system availability and experience for Kenyans. Concerns regarding poor public communication by SHA, Honorable Speaker, SHA is employing the following strategies: collaboration and partnership with other MDAs in carrying out public education and awareness, enhanced use of soft as opposed to hard information education and communication materials, leveraging on SHA branches network and Huduma centers for service delivery, partnership and support from development partners, working closely with grassroots leaders, including NGAOs, for enhanced communication, awareness and registration, and use of alternative media, including social media, to reach a wide spectrum of the population. On inadequate service delivery under SHA, Honorable Speaker, the SHA benefits package and tariffs, I'll be able to table them on this, and members can be able to go through it. On strategies that the ministry is implementing to ensure disadvantaged groups are fully covered under SHA, Honorable Speaker, identification of the indigent population through proximity testing as required by SHA Regulation 19 is ongoing, Honorable Speaker. And the government budget allocation for indigent will also be a boost to be able to make sure that indigent population are well taken care of. On coverage for pregnant mothers and teenage pregnancies, this is under Linda Mama program, which is still ongoing, that ensures pregnant mothers, including teenage mothers, receive full health coverage. This is effected upon first contact at the facility. Mothers who are due for delivery and have not paid the SHA premiums, the Linda Mama program automatically identifies and pays their annual premiums covering the entire household. Currently, the State Department for Medical Services is responsible for payments of the premiums. Honorable Speaker, on concerns that despite the high premiums, patients in need of services are being turned away by hospitals. Several issues have been identified where members, despite having made payments, are deemed ineligible as healthcare providers. These include incomplete payment records in the SHA database, absence of corresponding payment reference numbers, payments made via real-time gross settlements and RDGs, and electronic funds transfer EFT methods sometimes lack corresponding PRNs. This omission prevents the automatic updating of individual member amounts, leading to service ineligibility. On payment variances, Honorable Speaker, discrepancies between PRN amounts and bank payments. When the amount indicated on a PRN differs from the actual amount paid, the system cannot auto-update the member's amount. This scenario necessitates manual intervention. Employers are required to upload detailed payment information, including employees' names and corresponding amounts, into the SHA system before remitting the payments. Then we have erroneous national identification numbers, which incorrect data entry, cancellation of payment registration numbers by employers. This also has an impact on employee eligibility. Then unprocessed payments. To mitigate this, Honorable Speaker, we have empowerment of branch officers, member service, self-service application, employer notifications, employer sensitization initiatives, development of information materials, simplified registration channels where we have accessible registration methods. USSD code, assisted registration, online portal, and physical locations where SHA branches and Huduma centers provide in-person registration service.
How much more do you have to go?
2 minutes.
Good.
On integration with the National Registration Party, Honorable Speaker, this is basically for data verification, data cross-referencing, and then, Honorable Speaker, measures the Ministry is taking to ensure the informal sector and the indigent populations are registered under SHA, where some of the challenges faced in informal sector registration in SHA include low awareness and sensitization, irregular and unstable income, and lack of formal identification. So what is SHA doing to mitigate this? We are doing mass awareness and sensitization, where you utilize community health promoters, vernacular radio stations, TV campaigns to reach informal workers in their local languages. This ensures widespread understanding of SHIF benefits and encourages voluntary enrollment. Crossroads roadshows, flexible payment methods. Under this flexible, we allow informal workers to contribute through monthly mobile money payments, e.g. M-Pesa, making it easier for them to afford and maintain coverage despite irregular incomes. Integration with SACCOs and chamas, partnerships with county governments, engagement with informal sector associations such as Border Association of Kenya, then insurance premium financing, where we collaborate with microfinance institutions and government funds like Hustler Fund to provide credit facilities for premium payments, ensuring affordability and reducing dropout rates. Targeted communication, where develop specific messages for the elderly, poor, and vulnerable groups using simplified content and trusted community influencers to drive awareness and registration. Then we also encourage CDF budget allocation, where we advocate for constituency development fund allocations to sponsor SHIF premiums for vulnerable groups, and this is where the members come in, ensuring equitable access to health care. And then public-private partnerships, where we partner with microfinance institutions, NGOs, to extend healthcare loans for payments of premiums, and donor agencies like AMBAT and UNHCR. Honorable Speaker, the committee has also made our own recommendations, where we shall be engaging MOH and SHA in a retreat to look at the debts that are owed to the defunct NHIF, and will also engage them further as most of the issues, such as the mean testing tool used in the informal sector, needs to be looked at to improve its reliability and accuracy through field visits and not online. Then verification of health services by quality health assurance officers with technical knowledge to detect and eliminate fraud. SHA has inadequate visibility and capacity to confirm if services being claimed by contracted facilities are rendered. We will also be looking at the benefits package under the Primary Healthcare Fund, which needs to be enhanced. And also the State Department for Social Protection to leverage on the data provided by SHA and avoid subjecting the indigents to fresh mean testing. Honorable Speaker, the Public Service Commission has approved a staff establishment of 815 for SHA, and therefore the SHA board should follow the law as per the SHA Act 2023 transition clause in its recruitment of the staff. All former NHIF who will not be employed under SHA will be deployed within the Public Service Commission or exercise the right to retire under the Act. Honorable Speaker, thank you. I submit.
Thank you, Honorable Bukose, for that comprehensive statement. Yes, Chepalungu. Yes, there's one next to you. Okay, there you are.
Oh, yes. Thank you, Speaker. While we appreciate the efforts that our Chair Health has taken to give us that statement, and equally, while we appreciate what SHA has done, SHA has a very successful story, and particularly to one of my relatives, my aunt, who got injured, and 200,000 was required. We paid SHA, and in full, SHA paid all the hospital bills. And while we say the same, Honorable Speaker, there are situations that at times we wonder, some hospitals, or is it the SHA itself? Because there's a case of one of my residents, someone called Wilson Keter, who went to Karen Hospital for heart surgery, and on request for approval, out of 1.3 million that was required, only 78,000 was paid to this particular patient. And we, as members of parliament, when we go to these particular families, they give us such questions. And in so, Mr. Speaker, I only wanted to comment on that and to seek further clarification on why in some particular situations, SHA pays the whole amount, and in some situations, like a case of Wilson Keter, who comes from Lelechonik village, whom I attended his fundraising last week, SHA only paid 78,000 out of 1.3 million that was required for him to undergo heart surgery. Thank you, Honorable Speaker.
Thank you. Milemba.
Thank you, Honorable Speaker. As I appreciate the very comprehensive and long statement given by the Chair, Health on SHA, especially the updates that we did discuss in Naivasha and other emerging issues. Honorable Speaker, I want to be quick to indicate that there are, as he did this, he should be able also further to explain some contemporary issues that are actually with us and which the MATIANG'I would want to know. Number one is the issue of the private hospitals. You know, as you give this very comprehensive statement, and I'm a statler follower of SHA, the private hospitals are on strike. That's how the language I can use given my background of trade unions. And you notice that that's affecting the communities and the society. I thought you should speak something on this. What is this correlation between the old debt of NHIF and how is it affecting now the operation of SHA to the extent that there are now some hospitals that are now not taking patients for treatment because of the old sins, if you may allow me to speak on that as the one of NHIF. Then there is also the informal sector. You know, the origin of NHIF, which SHA seemed to borrow from and we support, was the NHIF, and that one was founded basically by workers. The fact that the informal sector is not coming on board will really take us to a corner where we shall have a very small population trying to contribute for the entire country, and it will not work. So I want you to come out clearly on this so that you explain exactly how we shall onboard the informal sector for this good SHA to work. Otherwise, we shall be in a situation whereby a very small population of workers are the ones who are contributing to the SHA, and this will not work properly. Otherwise, Honorable Speaker, there still need room for improvement. I want to thank the chairman because at least the discussion is live and ongoing, but the registration may not be even as perfect as we would expect. Thank you.
Nikal.
Thank you, Mr. Speaker, for giving me this opportunity. I'm very grateful. I was supposed to read this, but I didn't. That was then, and this is now. Mr. Speaker, the report is actually, I'll support it, as read by our chair. It is basically an interaction between the ministry and SHA management and the committee, and the contents are actually correct. And it is mainly the effort of the ministry and SHA are making, which, as we know, have not resulted in the results that we all expected, and hence the outcry that we have. However, if you look at those efforts, the efforts actually look fairly reasonable, and if implemented, should actually be able to get us where we are. Now, what our committee has recommended is actually on the observations of those reports and what needs to be done to make those efforts yield better results. But of our recommendations, Mr. Speaker, the most important one is actually the retreat and the meeting that we are planning with the ministry and SHA management. Because, Mr. Speaker, the main problem that we have really noticed in all this is the management of change. It is the management of change which is a problem. The concepts may have a little problem, but not that much. And if you look at these areas of change, it's the liability and the assets that SHA took over from NHIF. And if you look at now, as it now, Mr. Speaker, the current problem we are having of hospitals actually closing up is related to the liability that SHA inherited from NHIF. So that is an area probably we should have looked at much better, because now, as we are very unhappy with SHA, ideally this is a transition issue, and it raises the question that what happened to the money that NHIF raised and what happens with the debts then? So it is a change that we are dealing with. If you look at the area of registration, the registration for NHIF, Mr. Speaker, was straightforward. You registered as you paid. So every time you are registered, you are paid, and you could access the services. But what we have now, this registration has actually two components, two major components. You register, and if you pay, you are in SHA 2.7%. Then now you actually are liable to get, you can now get treatment under SHA, and things can be paid. But there's an element when you are registering and you have not paid, but you are still entitled to services at level 2 and level 3, for which we actually have to pay money. And what is happening is that even the little money that the government has put in has not been used because of structures that need to be put in place. So again, it is an issue of where things can work and are not working. The other one is the approval of services that people need and the payment system. The honorable member has just said in one case, the full payment was done. In another case, a very small portion of the payment was done. Again, it is because of you are dealing with two systems. One, if you are level 2 and 3. One, if you are in level 4, where you are in full SHA. And then also the benefit packages that are put in place, and depending in the hospital where you go. In some hospital, you will need co-payment or co-insurance. Again, these are things that they are actually in this system, but they have not come out well. The other area, Mr. Speaker, is the issue of human resource. To transit the human resource from SHA to NHIF, and as you can see, the numbers are so different, but all those people are there, although they are now all there as employees of the Public Service Commission who are now seconded to SHA, but these are not people who can work wholeheartedly, because only 800 out of the 1,700 are going to remain there, and nobody as of now knows who will remain. So we don't expect these people to work. So again, that is a system that we are dealing with. So Mr. Speaker, why I say this meeting is important, we as a committee then will have to look at this in fair amount of details in a more sober manner. And Mr. Speaker, let me say that in some areas, we may even have to look at the law. We did it very fast, it was desirable. But should we find that there is need for us to look at the